Welcome to Spine Academy. In this video, we're going to discuss the role of confirmatory studies in evaluating a patient with cervical spondylosis. Specifically, we're going to talk about the role of EMG nerve conduction study and the role of injections in evaluating a patient who has cervical spondylosis. This is an excerpt from a broader course on the clinical evaluation of patients with cervical spondylosis. If you're interested in seeing the full course, we've left a link in the description. So now we've spoken about getting a good history, doing a good physical examination, and reviewing imaging. And in my experience, that pretty much pertains to every single patient that I see that I'm evaluating, whether it's for neck or some other part of their spine. These studies that we talk about next are studies that we don't get 100% of the time, but I broach it specifically to talk about what these studies are in case you or someone has had them, or if you're thinking about ordering them if you're a clinician. And also talk about the role that they can play in helping you, on some occasions, really help make a diagnosis. So if we take a step before this and really think, like, where are we now? We've gotten a good history, we've done a good physical examination, and we've looked at their imaging. The goal first is to synthesize that information. So we want to organize the symptoms into symptom patterns. So again, talk myelopathy, radiculopathy, neck pain, kind of think in a structured way so that you can kind of understand what you're looking for and what you're trying to treat. Then you look for concordance with the physical exam, as we said earlier. So somebody who has, let's say, a C6 radiculopathy, you're looking for specific patterns of weakness, maybe specific patterns of numbness, reflex changes, things like that, to see if those fit together. And that helps if they fit, and it makes it confusing if it doesn't, obviously. Then you want to correlate their symptoms and their physical exam findings with what you see on the imaging. So the MRI, the CT, and the x-rays, I get them routinely or more or less routinely, but you're trying to correlate them to identify structural causes for the symptoms and physical exam findings that you have. And then often those things don't all line up. Like sometimes you'll say, boy, they sound like they have a C6 radiculopathy, but they have a pretty big C6-7 disc herniation, or vice versa. Or they have some other structural. I can't find anything on their imaging to explain the symptoms they have, but they have exam findings and symptoms. Things don't always line up. Not every nerve, not every disc has read the book. And so trying to be organized can help you figure out what problem you're trying to solve. And frequently in those situations where you're not 100% sure, you're like, could it be a C5 radiculopathy, or do they have a shoulder problem because they were involved in a car accident and all the symptoms started afterwards? And of course, people that are injured can have more than one thing injured at the same time, especially when they're close together. So when you're in a situation like that where you're trying to figure out, is this really coming from the cervical spine, there are a couple of things that I get routinely in those situations. One of them is I get cervical injections. Now, I may get cervical injections anyway in an effort to try to treat people conservatively, but the role of injections goes beyond just treatment. It can have important diagnostic value. I will frequently see patients who think, well, I don't want injections, that's just a Band-Aid, or I did injections and it gave me relief for like a couple days and I don't want to try them again because it wasn't worth the effort. And I get that. But at the same time, I think it's important to underscore that injections have not only therapeutic value, or maybe not in their case, but certainly can have diagnostic value as well. So a response to injections can be very valuable, and we'll talk more about it in some detail, but really think about if somebody gets an injection to their cervical spine and all that pain in their arm goes away, even for just a couple of days, if nothing else, it at least says it's coming from the cervical spine. And then the second study that I often will get in those situations is an EMG nerve conduction study. So that is electromyography nerve conduction study, which you often have to send to a specialist to do. And that is a test that looks at nerve function. It can help lend some insight into, are we dealing with the nerve? Where is the problem with the nerve? Is it musculoskeletal, etc.? Try to lend some insight into where people's symptoms are coming from and how to make sense of them. So the first thing to talk about is going to be injections. There's a lot of different types of cervical injections, and that's kind of outside the scope of this, not only from a time standpoint, but also since I don't do injections. Usually it's performed by a specially trained physician, but the types of injections that are done are epidural injections, sometimes selective nerve root injections, although those are a little bit controversial and inconsistent. Not everybody does those. And of course, facet injections as well. Those are injections that target the spine. There are other types of follow-up injections you may have heard of, radiofrequency ablation or rhizotomies, trigger point injections, etc. But these are the kind of most common that are useful from a diagnostic standpoint in my perspective. Usually these injections are done by specialists that really train in this. So these are different types of, whether it's a physiatrist, which is a physical medicine and rehabilitation doctor, often they're specially trained in fellowships for spine care, or anesthesia pain management. These are anesthesiologists that usually do a year or two of extra training afterwards to do some of these interventions as well. Some neurologists will do the same, but these injections are typically performed by specialists. And if you're a patient who is seeing a spine surgeon, they often will send you to somebody they may have a good relationship or trust to do these injections. And of course, if you're a clinician taking care of them, it's important to develop good relationships with honest, capable people who can do these injections in trying to figure out what's going on with your patients. So when we ask people to get injections, it's important to know what they did. So I often will get the procedure. It's important to know what was targeted. It doesn't always have to be selective. If somebody gets a cervical epidural injections and their symptoms go away, at least you know it's cervical. If you're trying to figure out if it's C6 versus C7, that can sometimes be a little bit more difficult for injections to resolve because the liquid that they put in can kind of bleed over into other areas. It can kind of leak into other areas. You can't like hang your hat on the fact that they said they did a C7 and it must only be at C7. So selective injections are nice, but they're not essential. But regardless, you have to know what type of injection they did to be able to make inference about where the symptoms are coming from and know where the injection was given, like what part, what level it was done, and where the contrast may have gone and where the steroid may have gone. It's also important to know the extent of relief. I can't tell you how often people come in and say, I had injections that didn't do anything for me, but then you talk to them about it and it can mean a lot of things. Some patients, yeah, they got a lot of relief, but it lasted 3 days, and in their mind that like wasn't worth the trouble. But the fact that they got a lot of relief can be very valuable. From a diagnostic perspective, can be very valuable. Sometimes people say like, yeah, I mean, it helped me for a few weeks, but it was just a little bit. And those are all different answers. So understanding how complete was the relief, was it a lot of relief, a little bit of relief? Did they get no relief at all? Not even transient. If you ask them, I got an injection, it didn't even change a thing. I didn't feel better, even on the drive home, I didn't feel better, never got better along the way. That also has different implications, right? That seems to favor like, maybe it's not coming from the cervical spine. Then how long did the relief last? And it's not uncommon for people to think, oh, that doctor did a bad job because the injection didn't help me. But if it's coming from a shoulder, an injection in the neck isn't going to help. I often will ask people to get a second injection just to be sure. I don't know that I could really hang a full diagnosis off of one injection that didn't work. But if somebody gets 2 cervical injections and it didn't give them even transient relief, not even a little bit of relief, you can almost use that diagnostically to say like, it may not be coming from the cervical spine. I get much more cautious about some type of surgical intervention if they got not even transient relief from cervical injections for things like cervical radiculopathy. Now they may not help with neck pain, they may or may not. They certainly, I don't use them for myelopathy, but there's a very important role for cervical radiculopathy in looking at cervical injections. The second study that I get, which is a confirmatory study, so again, I don't get it in everybody, is an EMG nerve conduction study. And you'll see this acronym here, EMG/NCS, which stands for Electromyography and Nerve Conduction Study. So most people have heard of an EKG. This is where you're looking at heart function. This is looking at muscle function. It's done the same way. It's a test that's designed to look at nerve function. And it will look a little bit at muscle function as well for people that have other neuromuscular problems. It's usually performed in the office. It's usually done by a neurologist or a physiatrist. There are some primary care doctors that are kind of trained in it or have a box that will do it or have a tech that does it. But I tend to preferentially send people to real experts on it, people that do a lot of it. Because it's important in the interpretation of it to have a lot of experience. So generally it's neurologists and physiatrists. And if you're a patient, often your spine surgeon may send you to somebody specifically to get that done. And of course, if you're a clinician, it's important to kind of develop a relationship with real specialists that you can count on doing a good quality EMG, because they're not all the same, just like many things in life. Now, this procedure involves testing muscle behavior, and it tests it with needles. It also looks at nerve conduction, so there's 2 different dimensions to this. So for example, the technician will put needles into the muscle to see how the muscles react. And that recording is a big part of the electromyography. And then they also will test conduction. So generate a stimulus, how long does it take to get here, how long does it take to get there? And there are certain kind of thresholds for what's a normal velocity for a nerve. And if that's diminished, it may indicate that there's a problem with the nerve conduction. And there's a variety of different types, but that is why an EMG nerve conduction study can be valuable. Now, if you've gone and had one of these done, you get some report that looks completely inscrutable. You look at it, it basically shows you all these muscles that put needles into and how they behaved. Now, to a clinician, when I look at this, I care about how many muscles do they put it in. Every muscle they put it in, they can make a comment on. If you get one of these and you have like 3 muscles in there and not a very detailed exam, it's hard to make meaningful inferences on that. Whatever the impression says at the end, how accurate it is has a lot to do with the resolution of it. And so we want to see that they've really tested some relevant things. So one of the things you'll see here is the right C7 paraspinal muscles. That helps you verify that it's truly coming from the cervical spine. And it's not important to kind of get into what this data actually says or what these waveforms mean, but when looking at this raw data, you want to know what muscles were tested. And roughly, when I'm looking at these, I kind of look at, is it on this side, are there abnormalities, or is it on this side of it? And I draw a line kind of right down the middle here, vertically. And these early features that you see are typically signs of active irritation, and the farther ones are chronic. And I'll get into that in just a minute. But this is what the output looks like from an EMG nerve conduction study. So when you go to a technician, or you go to an office, the technician does this procedure, a clinician will interpret all that information. What they are looking for is patterns of abnormality. And for example, they may see certain muscles involved and say, gosh, these muscles involved, that must mean that they have a C6 nerve problem, because that's the only way that those muscles intersect, or C7 distribution, or they have some other type of peripheral nerve process. But if you really take a step back, what the clinician has is raw data, and they're making an inference about where that must be coming from. So I often will take that out of it as subjective as well and say, well, what raw data do we really have? Because yes, in general, C7 may go here, but maybe this nerve didn't quite read the book, or that muscle didn't quite test out exactly right. None of these tests are perfect, so I like to look at the raw data, but the raw data has implications in looking at patterns of abnormality. It helps us figure out chronic versus active. And I won't get into that a whole lot, except to say that when somebody has acute irritation of a nerve, we call that active or acute radiculopathy, sharp shooting pain that goes down their arm, numbness, tingling, sometimes weakness. When it's chronic, think that that has been there. That may be nerve damage that has been there for a long time. The features of it are different. It's often burning, toothache type pain, hypersensitive. There are a lot of different symptoms, very different from the sharp shooting lightning bolt going down the arm type of a pain. That may be more indicative of chronic radiculopathy. And the reason that's important is chronic radiculopathy may or may not get better if you take the pressure off. In other words, if there's old damage and the damage is done, surgery may not help it. We sometimes still do them for other reasons and stuff, but as a general rule, chronic radiculopathy may or may not respond well to surgery, and so knowing that will help with the decision making. We're looking for cervical versus peripheral problems, and this can help as well with the EMG. So is it a problem truly coming from the neck, or is it coming from further down? And there's a few different features that we look at to help make that distinction. But one thing I will say is that it's important that the technician put needles typically into the muscles of the neck. There can be a little bit of gray area with it, but it's useful to try, and I think can have valuable implications in figuring out where symptoms are coming from, whether it's the neck or the peripheral nerves. Which nerves are affected is obviously how people use it. Now, I don't, again, hang a hat on the idea if somebody says in the impression this is C7 radiculopathy, if it doesn't fit with the symptoms and doesn't fit with the imaging, I may not say 100% that's what it is, but it does help us figure out what muscles are involved. That's very accurate. Muscles don't lie when they put a needle into it. And so I will try to use that to make sense of where people's symptoms are coming from. And then it helps us look for more diffuse neurological or neuromuscular or musculoskeletal problems as well. People can have other types of, like ALS or other conditions that can affect it, peripheral neuropathy that can affect things as well. And all of that is useful information that comes from the EMG nerve conduction study. So the value of getting these confirmatory studies, injections, sometimes they can be therapeutic, but often diagnostic, an EMG nerve conduction study is to help establish or validate a diagnosis. So when you evaluate a patient, you want to have a sense of what is their diagnosis? Where are their symptoms coming from? And it may be from more than one thing. It helps you assess the reversibility of the symptoms. And as an example, if somebody gets an injection in the setting of radiculopathy and their symptoms get better, but not for very long, at least you know if you cool that nerve off, it should get better. And surgery usually is a little bit more favorable in that situation. It helps to look for alternate contributors because there may be more than one thing going on. Do they have a peripheral nerve problem? Do they have a shoulder problem? Some other systemic neurological condition that may be superimposed on it? Because that will help inform not only how you manage it, but also help figure out like how likely are people to get better, so you can give them realistic expectations for how they should do afterwards if they do end up undergoing some type of surgical treatment. We use those studies not systematically, but frequently enough. What's important by this point is that you feel that you have a very clear sense, or as clear as can be, sense of where people's symptoms are coming from, and that will inform, importantly, how they get managed.
Thank you for watching this video. I hope you found it informative. If you've enjoyed it, please like and subscribe. If you have any questions, comments, or ideas for future content, we'd welcome them in the comment section below.